Good afternoon, everyone. Welcome to this WHA side event, Stroke Overlooked and Underfunded, Turning the Tide on the Global Stroke Crisis. Stroke is a leading cause of disability and death worldwide, yet it remains largely overlooked in global health discussions. I will narrate a true story which transformed my professional career as a neurologist. I started my neurology career as an assistant professor, and I saw several people coming with strokes. They were young, below 45 years of age. So one 39-year-old lady came to me with a severe stroke. She came out of the window period, what we call the golden hour, and she had acute treatment in our hospital, but she had moderate disability. And her daughter, who was doing her first year in the college, she became the caregiver. And I did not realize the importance of caregiving. After 3 outpatient clinic visits, then I asked her what was she doing. And she was in year 1 of the college, but because she has to take care of her mother, she had to discontinue her studies. So that was the impact on the family because she had to take care of her mother. More than 2/3 of the stroke occurred in low and middle income countries, where the average age of patients with stroke is 15 years younger as compared to high income countries. Every year, an estimated 12 million new strokes occur, and more than half of them will die, with 2/3 of survivors affected by long-term disabilities, as illustrated from the patient narrative, which I shared with you. The economic impact of direct care and lost productivity is about $891 million in 2017, and if we do not act by 2050, this annual cost will rise to $1.6 trillion. The Global Stroke Action Coalition is the first ever global advocacy movement dedicated to reducing the burden of stroke for everyone, bringing public and private sector partners together. We are working to drive urgent commitment, investment, and action on stroke prevention, treatment, and continuing care. Most strokes are preventable, treatable, and recoverable when the right policies, systems, and investments are in place. During this event, the Global Stroke Action Coalition will outline 5 urgent actions for leaders and policymakers and launch Every Minute Counts, a campaign to inspire and mobilize momentum in the lead up to the September UN high-level meeting on NCDs. Today's program will have 2 panel discussions moderated by Claire Duell, former BBC correspondent, and we have experts from WHO, people with lived experience, industry, World Stroke Organization, and ministerial representatives from various countries. On behalf of World Stroke Organization and the Global Stroke Action Coalition, I welcome you all again, and I hand over the session to Claire Duell. Thank you.
Thank you, Gerard. Thank you. And as you heard, there is a global stroke crisis. It's one of the top 3 causes of death and disability worldwide, yet it's overlooked and underfunded. How do we turn the tide? We're going to be hearing from health ministers from Panama and Brazil, Health Secretary of Bhutan, and a senior advisor to the Ministry of Health of Egypt. And we're also going to be hearing from members of that Global Stroke Action Coalition that Jayaraj just mentioned, plus experts from WHO and IFPMA, the International Federation of Pharmaceutical Manufacturers Association. Please do use the hashtag Stroke Action Now and be ready to ask questions of our very distinguished panelists. Let me welcome the first panelist onto stage. Vanessa Peabody is Deputy Director of Health Progress at the International Federation of Pharmaceutical Manufacturers Associations, which I shall refer to as IFPMA from now on. Vanessa leads global initiatives to expand access to medicines and strengthen health systems through public-private partnerships. Dr. Alakos Sietha is a global leader in disability, rehabilitation and non-communicable diseases policy, and she currently leads the unit responsible for NCDs at the World Health Organization. Professor Bo Norving is a world-renowned stroke expert and Senior Professor of Neurology at Lund University in Sweden. He's currently the co-chair of the Global Stroke Action Coalition and previously served as president of the World Stroke Organization. And Dr. Melinda Roaldsen is head of the Clinical Research Department at the University Hospital of North Norway and serves as Associate Professor and Vice Head of the Department of Clinical Medicine at the Arctic University of Norway. In 2023, Dr. Roaldsen had a stroke and became a strong advocate for patient-centered care. So, Melinda, let's start with you, if I may. Can you tell us what happened, the treatment and the care that you received?
Yes. It was Saturday, the 14th of October. It was just another ordinary day and weekend. I'd been with my daughter earlier that day to swim in the city public community indoor pool. I was at home, the safest place one can be. The very first symptoms started in my hand, and thereafter spread quickly to my whole right arm. It grew heavy, and I could not move it at all. I acted immediately. Asked my husband to call an ambulance. My exact words were actually, "I do not mean to be overly dramatic, but I believe I'm having a stroke." I waited by the front door. Both my children were at home, and my first instinct was that I wanted to keep them safe and shield them for as long as possible from the harsh truth of it all. I lost my ability to walk on my right side of the house, and I lost my ability to speak sometime before I arrived at the hospital. But I received excellent and rapid acute care. This is extremely fortunate. Only 40 minutes from the symptoms started. It is quite exceptional. Time is brain 1.9 million brain cells die every minute during an acute stroke. And I received all the treatments modern stroke care has to offer. Thrombolysis, thrombectomy. This is a procedure when one goes in through the groin manually with a guide wire and a fish, the blood clot out. And I got a stent. Despite all this, the reality had to face when I woke up after the procedure was grim. I could not move the right side of my body, the whole right side of my body. I could not walk, I could not speak at all. In fact, I couldn't produce a single sound. I even had swallowing and breathing difficulties and something called hypersensitivity. This is when everything feels excruciating painful, even the weight of the affected body part that touches the bed. I was in a state of utter despair. a feeling of claustrophobia, fear, dread, and in more ways than one, I had lost myself. I felt I couldn't trust myself. My sensory perception, I questioned everything. It felt like I had been sentenced to prison without committing a crime, without a possibility of pardon. A prisoner of my own body, a prisoner of mind and circumstances. But in retrospect, I consider myself very lucky for several reasons. I recognized the symptoms at once. I was with somebody that called an ambulance. I live near a hospital with a comprehensive stroke unit, excellent acute care, a remarkable rehabilitation department that focus on effective evidence-based therapies and patient-centered care approaches. I spent 4.5 months training at a hospital, 7 days a week, with a personal assigned team and an individualized plan. It was tremendously hard, grueling work, but I did not do it alone. My team, my family, my friends, my community, and the most important of all, my country had my back. The systems were all in place. This is very important factors to consider for my success story. And after I came home, the rehabilitation continued without pause.
That's very good news. I imagine, though, that this life-altering event has changed your perspective.
Yeah, it has, especially because I was so lucky. I feel a heavy responsibility to speaking out and to fight against inequality in stroke care now more than ever, so that everybody that experiences a stroke is let out of their individual prisons, that they get the opportunity to heal optimally and find themselves again, like I have done. My insight is that it was the stroke knowledge, awareness, and acute stroke that saved my life without doubt. But it was my rehabilitation team that brought me back to a dignified, high-quality, meaningful life again.
And there is a wonderful video of Melinda on the World Stroke Organization website where you talk about the fact that soon after you were giving lectures and you even went snowshoeing like a true Norwegian.
Yeah, I put myself some goals that were past sky high in regards to the state I was in. The very first week I set those goals to go snowshoeing again and lecture again. And I couldn't, and I managed to fulfill my promises to myself within 6 months' time. But as I say, I did not do it alone.
Absolutely. And Bo, Melinda, it has a very positive example of treatment and especially rehabilitation. But it's a rare example, isn't it? Because we were hearing from the current president of the World Stroke Organization that there is a global stroke crisis. How bad is it?
It's very, very bad. We heard about one single case and a drama that you can tell about, but we speak a lot of single cases of stroke. Each year, as we heard, there were 12 million people who have a stroke. 12 million people, 7 million who die, almost 100 million who are alive and suffer from a stroke. Vast majority are in the lower middle income countries. A high proportion are in the working age. So there's some numbers, whatever metric you have, stroke is up there among the very top every time. And moreover, we know that if we will not act on this, it will be even worse. By 2050, it will be increased by 30 to 50%. It will be beyond the capacity of the health system. We need to act. And for the target 2030 of 3.4 of a reduction of 30%, there are two diseases which are critical. One is heart disease, the other one is stroke. This is important.
Why do you think this stroke is so underfunded and overlooked? We hear a lot about heart disease, but why is stroke overlooked?
Stroke has a sad background because for a long time there were no therapies for stroke, no prevention, no acute therapies really, and that's really changed. But still we are suffering from this, and stroke is one of the prioritized diseases in the declaration, but it's been hidden under cardiovascular diseases. Many people think cardiovascular diseases, this is heart disease. Cardiovascular diseases by definition is heart disease, stroke, other vascular diseases, and stroke has been hidden. So we are left now with a prevention dilemma, really, that prevention is far too insufficient, far too slow. We have an important gap in terms of treatments, that the vast majority of the patients in the world do not get these therapies. So we will speak about the possibilities, the opportunities to change. We need to correct the position of stroke, really, to get it up where it belongs.
Yes, out of the shadows, as you say.
Yes.
Larkos, so we've heard that prevention efforts are too low, not enough treatment. Belinda was saying she was a rare example of rehabilitation. So how do we strengthen healthcare policy so that stroke gets the attention that so many people believe it deserves?
Thank you, and it is fascinating to hear your story, so thank you for that. And look, I think the right messages are given. It's important prevention, it's treatment, it is about rehabilitation. And I think that is also the power based on which we need to promote in governments stroke. There are different entry points for a stroke. You know, there is the entry point of non-communicable diseases that we use very often, is the entry point of neurological conditions that we also use very often, and we also use strongly at WHO. There is also the entry point for rehabilitation. The key that we need to emphasize much more is to countries and to governments is that if you ensure that this continuity of care is provided for a condition like a stroke, you will strengthen the whole health system. Because if you ensure that for a stroke there is a good acute care, good treatment, good rehabilitation, then that will be very positive for any other condition that has also an acute event as a start. So it's, of course, for acute coronary syndrome, but it also improves the services for whether it is a spinal cord injury or any other condition that has an acute start. So I think using always different entry points, but the same message, you strengthen the treatment, the rehabilitation for a stroke, you strengthen the health system and the services for all NCDs, but also for any other condition that has an acute event as a start.
And this comes out in the new strategic framework that you published recently.
Absolutely, and that is the reason why it is acute coronary syndrome and stroke because at the end of the day, you can also, you strengthen the services for acute coronary syndrome, you strengthen the services for stroke, but more importantly also, you strengthen the services for stroke, you strengthen the services for acute coronary syndrome. I think one of the keys of this framework is very well reflected by the story of Melinda, because Melinda said, look, I was fortunate that I could recognize the symptoms. And that is what this framework put a lot of accent on. We need to ensure that the symptoms and the signs are recognized as soon as possible so that a quick decision can be made to really start the acute care as soon as possible. And that is the accent of the framework in terms of saying we need to ensure that in primary care facilities, the personnel is well trained to recognize immediately that there is a stroke, so that it can be put in place, or the acute care can initiate it, or the transfer to another facility can be initiated. But having said that, so that is a lot of accent, but the nice thing about the framework is that it really provide detailed guidance what needs to happen at each stage of the care, and promote, for that reason, coordination and avoid fragmentation. So it's really the core, how this coordination needs to happen across the different steps in the treatment.
Yeah. Coordination, as you say, across the steps. We also, if I bring Vanessa into the conversation, we need collaboration. Collaboration from policymakers, survivors, neurologists, and the industry. So, how do you see that role of multi-stakeholder collaborations?
Firstly, I just wanted to say a big thanks to having me here. I mean, it's very special to me, particularly as my parents lost a very close friend, Celia, to a stroke only a few weeks ago. So it really brings it home, you know, some of this. Yeah, I mean, look, the industry, the pharmaceutical industry, believes strongly in multi-stakeholder partnerships. I think over a third, 110 out of over 300 collaborations are on NCDs, on non-communicable diseases. We work with over 500 cross-sectoral partners. So I think, you know, for us, it's very much in our DNA to be working with the different stakeholders. And the beauty in having multi-stakeholder partnerships is that everyone brings different skill sets to the game. You know, we all have shared messages, we have shared objectives. I think we need to not lose sight of that. Sometimes we do. And particularly in resource-constrained settings, you know, I think there's really a need to think about how we can work better together to maximize impact. And that, again, has been a challenge, you know, for many years in terms of how to bring in the industry. Maybe one thing I did want to mention as a concrete collaboration is the Angels Initiative. I know that might come up in the conversation later. A number of our member companies have supported this. This is since 2016. I think 7.5 million patients, you know, sort of helped in terms of improving survivability, if that's a word even, and, you know, disability-free lives in over 6,000 hospitals and 1,400 of them stroke-ready. So it's a remarkable, you know, example of what we can achieve when we work together.
This is done by two of your members?
No, this is a number of our member companies who support this with other different partners, and I think it's just a great example, at least in the context of stroke, around multi-stakeholder collaboration. I think just to say that also as the industry, in terms of working together, we need to move beyond seeing industry and other parts of private sector as simply providers of commodities. I think there's a missed opportunity there. We need to see the skill sets and expertise that we bring beyond the R&D. We have expertise in capacity building, manufacturing, you know, partnerships, and we need to find ways to leverage our constituents much better. So yeah, I just wanted to bring that in.
Yeah,
Thanks.
no, absolutely. Yes, you're not just, it's not just about money, it's about everything else that goes with it. I hear you very clearly. Of course, there's always the issue, isn't there, especially with the low and middle income countries, about affordability. So what can we do to reduce costs? Because I think traditionally a lot of LMICs, it was about prevention, treatment, rehabilitation. Not so easy. So how do we reduce those costs?
Yeah, thanks, Claire. Look, I think that's a really tricky question because I think we also need to look beyond costs. I mean, if we look at sort of, for me, one of the things that we're working on actually in the industry and trying to think about how we do this with others is getting others and governments to understand better the return on investment when you take an integrated multi-morbidity approach. That includes prevention. And I think that's important because we're still far off the mark in terms of how much we're investing in primary and secondary prevention. We also need to look at access much more holistically. I was really blown away by the fact that in 2017, 21% only of LMICs, low and middle income countries, had a CT scanner. And I understand that in stroke, a CT scanner is a really crucial basic diagnostic tool. And that, for me, really says it all. I think we need to find ways, whether through universal health coverage or elsewhere, to help countries understand how we can make more investment in some of these areas, knowing full well that, you know, this isn't fully interconnected agenda. I think I read also that somewhere in between 5 to 30 times greater is the risk of stroke you have if you have chronic kidney disease. So this is just to illustrate it's really a joined up agenda, but we're missing that interconnectedness. And I think if we understand that and can grasp that more, then we can make some big strides on the investment side. Thanks.
Bo, let me ask you perhaps to respond to what you've heard from Alakos and Vanessa.
Yes, what comes to my mind, of course, is that we are fortunate now with stroke. We are putting up stroke up top of the agenda to where the place it should be. And we are fortunate that we have some of the most cost-effective interventions in the whole field of medicine. And that is in the field of prevention, that we know the risk factors, we know that we can prevent stroke, we know that we can cut stroke in half. There will be enormous savings from that, but it doesn't come for free. But we have all the potential here, and we have the revolution with the new therapies, which are dramatic. Some of the most efficient in the whole medicine with reperfusion therapy, stroke unit care. And we used to look at coronary heart disease and say, this is standard, you should have the interventions. Now we have the interventions for stroke. They are equally effective. They are recommended in all WHO documents as recommended services. We have it on the higher level. Now the problem we have, this is investment, and this is to have the implementation and reach out, really.
Yeah, and because Melinda, as an advocate, you in Europe in particular have been working to ensure that there is implementation and there are national stroke action plans.
Yes, that is correct. And the important thing is that the national stroke action plans must encompass the whole chain of care, from prevention to acute care, to rehabilitation, to a life after stroke. And in Europe, we have recently acknowledged and we experience that this action plan seems on the rise, but we are driving change to the stroke action plan for Europe.
Now, one of the reasons that the Global Stroke Action Coalition set up was because there is a UN high-level meeting in New York in September. So I'm very briefly going to ask each of the speakers what they would hope to come out of that before I take some audience questions. Vanessa, briefly, what would you like to see?
Yeah, thanks, Claire. I probably some of you in the room know that the zero draft is already out of the political declaration, and I saw that there was a reference to multi-morbidity, which is great. I still think we can be much more powerful in our language about how this is all interconnected. I think there is so much lack of awareness on this entire agenda, so I'd like to see stronger language in the declaration on that. Thanks.
Yeah, Alakos.
I would like to see the political declaration as a starting point, not as an end point. I think we are concentrating so much now on the declaration that we forget that actually what is important is what comes after. And I think it's absolutely right to have the focus on preventing premature mortality, because it's absolutely right. However, there is no mention that is not only about ensuring that people live longer, but also that people live well. And that is something that has really not come strongly enough in the current draft.
Yeah, quality of life. Bo.
Yes, again, correction. Correction for everything that has not been done since 2011. Now we need to do the action. Now is the time to do it. And now is the time to put stroke up there where it belongs, along with the other main NCDs, really. So now's the opportunity, including national stroke plans. These are the winners. Thank you.
Melinda.
Together, if we join forces, healthcare professionals, both clinicians and academia, policymakers, and the lived experience community. My hope is that once and for all, that we will all together make sure that we can come out victorious of this ongoing battle against stroke. The time to act is now.
Thank you very, very much to our speakers. I think we've got the message of what needs to be decided and done and implemented. Let's take a couple of audience questions. I most probably have time for one or two. If you'd like to raise your hand, say who you are, and if there is a specific member of the panel who you would like to answer the question, please tell us, and a microphone will go round. There's a lady at the back in red. It's always very good to wear red because we can see you.
Hello, I'm Taskin Khan. I'm the Director of Research and Policy at WISH at the Qatar Foundation. And my question is actually for you, Bo Noving. What did you think about the political declaration, particularly given the scene you set for stroke? And how do you think, critically, did it, was it good? Did it fall short? And how do you think there can be some sort of momentum towards the UN high-level meeting?
There we are. As co-chair of the coalition, the floor is yours.
Yes, I think the declaration is a starting point, and then it's for other parties to continue with that. Actually, there is very much of the items in the declaration that we can refer to, and I think the next step for us simply is to work on that and do implementation, really, and rather than maybe to look at small wording and language, now we need to act, really, because we are just in a war. The brain is under attack. The brain is with emboli and hemorrhages, and we can stop that war, we can prevent it, we can do it now, and there's an urgency about this. And I think this is the most important thing. Act now. This is what we need for stroke, and we will have a result.
Is there another question in the room for our distinguished speakers? Yes, the gentleman with his hand up.
I was going to wear a red tie, but I forgot. I have a question for the WHO. There's a lot of talk about national stroke plans, and that's the basis on which we're going to actually improve. Now, a lot of countries have developed stroke plans, and they may not need another declaration or an NCD action. So, from your perspective, which countries got it right, and what can we learn from those?
Yeah, let me say something about action plans for stroke. I think they are absolutely fundamental if the country is ready for it and to move specifically the agenda of stroke forward. Because there is a political commitment, and then that is what will bring action. However, we should not be paralyzed, or we should not really only promote stroke action plans, because for a stroke there are other entry points. If a country have an action plan, a multi-sectorial action plan for non-communicable diseases, use that action plan if the country is ready to move with it, and use a stroke at the entry point to say, if you strengthen the services for a stroke along the continuum of care, you will strengthen NCD services as a whole. If the country have an action plan for, let me say, rehabilitation, use it as an entry point, because is you can also say you strengthen stroke rehabilitation, you strengthen rehabilitation as a whole. So and we need also to be aware of the reality in many countries. Some countries had how many NCD action plans? We have sometimes 4 for cancer, for 4 different cancer, one for a stroke, one for coronary diseases, one for hypertension, one for respiratory diseases. So at the end of the day, the countries have 20 action plans that cannot prioritize and cannot be implemented. So my message is, if the country is ready for really focusing on a stroke, move ahead, and the political commitment is there, fair enough, and then you strengthen NCDs as a whole and the system as a whole. But if the entry point is different, use it too. So don't get disencouraged if countries do not have those specific action plans. For a stroke, there is always a good narrative to strengthen the health system.
Thank you very much, Alakas. Thank you for your questions. I am going to have to move on because we have some health ministers in the room who we know have very packed agendas at the World Health Assembly, so we don't want to lose them. I would like to thank our speakers. An example of a multi-sectorial collaboration on this panel. Let's hope you get what you want out of the UN high-level meeting. A round of applause, please. Thank you. As the president of the World Stroke Organization said at the start of this event, governments must seize the moment to ensure that stroke is recognized, prioritized and acted upon. So we're going to hear from some speakers from Brazil, Bhutan and Panama. But first, we're going to watch a video that the Minister of Health from Brazil, Alexandra Padilla, has sent to us.
É uma honra poder, na condição de Ministro da Saúde do Brasil, estar representando não só o Ministério da Saúde, mas todo o esforço do Sistema Único de Saúde brasileiro, num momento como esse, de um espaço de diálogo, de interação, de dar visibilidade a algo que é tão preocupante para o sistema de saúde do Brasil e do mundo, que são os acidentes vasculares cerebrais. Quero reforçar e saudar esse espaço de diálogo e, sobretudo, de convite para o grande evento internacional que estaremos sediando no Brasil no próximo ano. E aqui eu quero fazer uma saudação especial a todos os profissionais de saúde, pesquisadores nacionais do meu país, do Brasil, que junto com a comunidade acadêmica internacional está organizando esse evento tão importante no próximo ano no nosso país. Quero, antes de mais nada, convidá-los a estar presente nesse momento internacional no Brasil e dizer bem-vindos ao nosso país e conhecer, sobretudo, todos os desafios que nós temos para construir o Sistema Único de Saúde, um dos maiores do mundo e, sem dúvida, aquele dos países com mais de 100 milhões de habitantes, o único que busca ser totalmente universal e gratuito. O acidente vascular cerebral é um tema de grande preocupação de saúde pública no meu país, Brasil. É hoje a segunda causa de morte, perdendo apenas para a situação do infarto agudo do miocárdio. Além do óbito, que é extremamente grave, embora a gente venha conseguindo reduzir cada vez mais essa situação, a letalidade em várias situações, graças à capacidade de resposta, não só do sistema como um todo, mas sobretudo de hospitais cada vez mais qualificados, o acidente vascular cerebral também impacta fortemente a vida das pessoas, mesmo aquelas que felizmente não morrem, mas acabam adquirindo algum tipo de deficiência física, impacta o conjunto do sistema de saúde, com custos importantes do tratamento e dos custos da reabilitação, impacta também a economia de um país como o meu país, um país de renda média, que precisa crescer e se desenvolver muito ainda, também tem a sua economia impactada pela situação do acidente vascular cerebral ao tirar pessoas do momento produtivo econômico, do dia a dia do trabalho, do dia a dia da sua família, impactando na vida como um todo. Então é um grande problema de saúde pública e que exige cada vez mais do nosso sistema nacional público e dessa rede internacional uma preocupação e uma visibilidade que merece o acidente vascular cerebral. Eu tenho a honra de, quando fui ministro da Saúde pela primeira vez, no ano de 2012, ter criado o primeiro programa nacional, o Sistema Nacional Público do SUS, de prevenção, cuidado e reabilitação ao acidente vascular cerebral. Um programa naquele momento extremamente amplo, abrangente, preocupado desde a atenção primária em saúde, passando pelas equipes de urgência e emergência móveis, até pelos centros especializados de atendimento. Esse plano criou incentivos, recursos específicos para a adoção dessa resposta abrangente. Recursos e estrutura das unidades móveis de emergência, como recursos para a habilitação de centros especializados nos hospitais, com níveis diferenciados de acordo com a sua capacidade de especialização, com os recursos que podem ser implantados, com a qualificação naquele hospital, cada um desses graus de centros especializados recebendo incentivos financeiros diretos do Ministério da Saúde de forma diversa. Tudo isso, um desafio enorme que o Brasil tem, que é ter um sistema público, universal, de saúde, com 3 níveis de governo. Governo federal, Ministério da Saúde, os governos estaduais, regionais, os governos locais, municipais, todos eles com grau de autonomia, onde a coordenação, a indução feita pelo Ministério da Saúde é decisiva para que isso, que seja uma diretriz nossa, aconteça em todo o país. Então, um esforço complexo de pactuação e uma resposta abrangente. Esse é um grande esforço, além da estruturação de um programa como esse, de estudos e pesquisas. Eu quero ressaltar aqui o projeto Resilient, financiado pelo Ministério da Saúde, acompanhado inclusive com outras experiências em outros centros internacionais sobre o uso de tecnologia para o tratamento, que traz resultados interessantes a partir dos dados brasileiros, que contribuem cada vez mais para o avanço no tratamento da situação do acidente vascular cerebral. Algumas questões são prioritárias para que a gente possa enfrentar cada vez mais a situação do acidente vascular cerebral. Primeiro, reforçar cada vez mais a atenção primária em saúde e na capacidade das equipes de atenção primária em saúde cuidar da reabilitação. Por isso, a retomada nos investimentos da chamada Academia da Saúde, que a partir da unidade básica de saúde, com equipes multiprofissionais, inclusive com professores de educação física nessas equipes multiprofissionais, agir muito na prevenção, na atividade física. O segundo grande esforço, garantir cada vez mais a oferta de medicamentos acessíveis, gratuitos, sobretudo para hipertensão e diabetes, para toda a população. Terceiro, o Brasil continua sendo o país que luta contra o tabaco e reforça suas ações de combate a esse produto nocivo para a saúde. Quarto, nós retomamos o investimento nas unidades móveis de urgência e emergência. O Brasil tem um grande programa chamado SAMU, retomar os esforços dos investimentos nos centros especializados de cuidado aos acidentes vascular cerebral, investindo fortemente e apostando muito na chamada telesaúde. A partir desses centros especializados, o apoio por telesaúde às unidades de urgência e emergência, a atenção primária, a média complexidade, algo tão importante num país com a dimensão do Brasil e com as desigualdades regionais e econômicas que o nosso país tem. E apostar muito na retomada da formação de especialistas. E, sobretudo, queremos saudar esse momento e de reforçar a nossa articulação internacional, porque ela é muito importante, porque ela dá visibilidade para o tema, permite troca de experiências e garante algo muito importante, que é trabalharmos internacionalmente a oferta e garantia de medicamentos e tecnologias que muitas vezes pelos custos ficam apenas restritas às pessoas que têm poder aquisitivo maior ou às nações que têm maior poder aquisitivo, deixando sem acesso a medicamento e tecnologia os países de renda média, como o nosso do Brasil, ou os países ainda em situação de maior presença da pobreza, com mais dificuldades de manter um sistema de saúde. Nossa articulação internacional tem que manter visibilidade no tema, troca de experiências e articulação internacional, coalizão internacional para a garantia do acesso a esses medicamentos.
A round of applause. So I think we can hear that there is a stroke crisis. The stroke is, I think the minister said, the second leading cause of death in Brazil, but they have had stroke action plans and they have taken action, as he was recounting. I'm now going to invite onto stage our other experts. First, if I could ask the Health Secretary of Bhutan, Dashu Pemba Wangchuk, perhaps you would like to come and join me here, sir. The Minister of Health of Panama, Dr. Fernando Boyd Galindo, if you would like to join me on stage. Thank you. And I believe we have the radiology advisor to the Ministry of Health in Egypt, Dr. Mohamed Fauzi. Thank you, gentlemen. There we are. A first exchange. So what I'm going to do here is, first of all, ask them about the global burden in their countries and the response. And then we'll do a second round looking further ahead. So let's start in Bhutan. So tell us about the stroke burden and how you are developing your stroke care system. It will start immediately you start talking.
Thank you very much, Claire. I think it was very interesting to listen to the experts on stroke. And I'm from Bhutan, and I bring greetings from the Kingdom of Bhutan. I was very moved by Dr. Marendra's story. And in Bhutan, there are so many such cases, but not as fortunate. So it's a big story. I thank you for the opportunity to be here. And cardiovascular diseases in Bhutan are now the leading causes of death and disability. 28% of NCDs deaths in Bhutan are attributed to CVDs, cardiovascular. Alarmingly, our national data of 2024 also shows that there are younger patients who are also now susceptible to stroke. This trend reflects deeper social and behavioral issues, such as rising rates of hypertension, diabetes, tobacco and alcohol use, physical inactivity, and unhealthy diets. Yet, despite the challenges, Bhutan remains committed to a whole of government and whole of society approach in tackling stroke and NCDs in general. Let me take you to a brief history through Bhutan's progress in stroke care, a journey that was shaped by limitations, breakthroughs, and above all, determination. A few decades ago, stroke was not a medical condition. It was not a disease in Bhutan. It was a fate meted by angry spirits on unfortunate individuals. Such stroke occurrence was also rare, as NCDs were low, and so the belief was even stronger. But with the unprecedented rapid economic development during last few decades, NCDs rose in equal terms, and so did stroke cases. Today, 70% of all the deaths are due to NCDs. And over the last 6 years, on average, 1.4 patients are admitted in hospitals every day, and every 5 days, one patient dies due to stroke. In the early 2000s, stroke was often seen as a hopeless condition in Bhutan. I recall the story of a 65-year-old man from a very remote part of Bhutan being suspected of stroke, but we just had to send him back. There was nothing we could do. But change was on the horizon. Between 2006 and 2008, Bhutan acquired its first CT scan. Diagnosis became possible. Although basic, it was a critical step forward. Then in 2008, we began neurosurgical services in the country. One of our earliest success stories was that of a 32-year-old woman from another village. She was admitted to Thimphu, the capital city, in the hospital after suffering a brain hemorrhage. Thanks to timely surgery and care, she survived. And today she lives in a full life with only minimal residual weakness. Since 2010, Bhutan has made significant strides. We introduced thrombolytic agents, developed a national stroke protocol, and intensified public awareness through televisions, radios, print medias, and national observance like World Stroke Day and World Hypertension Day. Today, stroke is no longer seen as a hopeless diagnosis in Bhutan. It is a medical emergency, and our health professionals are trained to respond with urgency, skill, and care. Thank you.
Thank you very, very much for taking us through the revolutionary progress in Bhutan. I'm now going to move to the Minister of Health of Panama, Dr. Fernando Boyd Galindo, who will speak in Spanish. I'm afraid no hablo mucho español. So if you would like to, you're going to translate for the minister, who will talk about the crisis and the burden in Panama and how they are responding to it. Minister.
First of all, my thanks for the invitation, and I am very grateful for the opportunity to speak before all this distinguished audience. Excelentísimos colegas, distinguidos miembros de Global Stroke Association, autoridades presentes, damas y caballeros, es un honor dirigirme a ustedes en este prestigioso evento que representa un compromiso global en la lucha contra la enfermedad vascular cerebral, también conocida como ictus o accidente cerebrovascular, una de las principales causas de muertes y discapacidad en el mundo.
Okay, I will translate that. So he's saying, excellent distinguished member of the Global Stroke Association, attending authorities, ladies and gentlemen. It is an honor to address you at this prestigious event, which represents a global commitment in the fight against cerebrovascular disease, also known as a stroke or cerebrovascular accident, one of the leading cause of death and disabilities in the world.
Como bien sabemos, los factores de riesgos asociados a esta condición son ampliamente reconocidos. La hipertensión arterial, la diabetes mellitus, dislipidemia, obesidad, sedentarismo y tabaquismo. En ese sentido, Panamá trabaja decididamente en la promoción de estilos de vida saludables y una alimentación equilibrada. Recientemente hemos implementado el programa nacional RISA, Rico y Saludable, una iniciativa que orienta a nuestra población hacia el consumo de alimentos saludables, accesibles y nutritivos.
As we all know, the risk factors associated with these conditions are high blood pressure, diabetes, dyslipidemia, obesity, sedentary lifestyle, and smoking. In this sense, Panama is working to promote healthy lifestyle. Recently, they implemented the national RISA, which is Rich and Healthy program. It is an initiative that guides the population in Panama towards the consumption of healthy, affordable, and nutritious food.
I would say that RISA is like rich or tasty and healthy. In Spanish, is translated like RISA is rico y saludable. That's why I put it like that, so The whole country will follow it.
And also risa is laugh in Spanish, so that's also good.
Además, promovemos el uso de espacios públicos para la actividad física y hemos equipado nuestras clínicas a nivel nacional para garantizar el control integral de las enfermedades cardioneurometabólicas. Asimismo, hemos fortalecido la capacidad de nuestro personal de salud, asegurando que cuenten con los equipos de diagnóstico y medicamentos necesarios para tratar eficazmente estas enfermedades que predisponen al ictus.
So in addition, they promote the use of public space for physical activity, and they have equipped clinics nationwide to guarantee the comprehensive control of cardioneurometabolic disease. Likewise, they also strengthen the capacity of their health personnel to ensure that they have diagnosed equipment and medication necessary to effectively treat this disease and predispose to stroke.
Uno de los mayores logros de nuestro país ha sido la reducción significativa del consumo de tabaco, alcanzando una prevalencia cercana al 5%, la más baja de América Latina. Este avance ha sido posible gracias a políticas públicas sostenidas, campañas educativas, regulaciones estrictas y el compromiso activo de nuestras comunidades.
One of the key greatest achievements that Panama did is the reduction of tobacco consumption, reaching a prevalence close to 5%, the lowest in America Latina. This progress has been possible thanks to sustained public policies, educational campaigns, strict regulations, and the active engagement of their communities.
Un hito clave fue la promulgación de la Ley número 13 del 24 de enero del 2008 que establece medidas contundentes para el control del tabaco y sus efectos nocivos en la salud. Esta legislación prohíbe fumar en una amplia gama de espacios públicos, tanto abiertos como cerrados, incluyendo oficinas, medios de transporte, terminales terrestres, marítimas y aéreas. También impone fuertes restricciones sobre la publicidad, promoción y patrocinio de productos de tabaco y exige advertencias sanitarias claras en sus empaques.
A key milestone that they did is the law number 13 of January 24, which established a measure to control tobacco and its harmful effect on health. So this legislation prohibits smoking in a wide range of public space, both open and closed, including office, means transportation, land, sea, and air terminals. It also imposes strong restriction on the advertising, promotion, and sponsorship of tobacco products and requires clear health warning on their packaging.
Estas acciones han sido fundamentales para reducir la exposición al humo de tabaco y desalentar su consumo, especialmente entre los jóvenes. Recientemente, un grupo médico en Panamá desarrolló y publicó un estudio sobre el manejo agudo del ictus en el Hospital Irma Lourdes Sanetatos, un hospital de segundo nivel de complejidad.
These actions has been essential in reducing exposure to tobacco, smoke, and its issue, especially among young people. Recently, a medical group in Panama published a study about the management of stroke.
Durante el periodo 2022-2023, este centro recibió un promedio de 5 pacientes por día con enfermedad vascular cerebral. De estos, el 83% eran hipertensos y el 30% diabéticos.
During the period 2022-2023, this center receives an average of 5 patients per day with cerebrovascular disease. Of these, 83% were hypertensive and 33% were diabetic.
Más de la mitad de los pacientes, 52%, no conocía el tiempo de inicio de los síntomas y el 26% llegó al hospital con más de 12 horas de evolución. Esto impidió la administración de trombólisis, tratamiento para disolver el coágulo que causa el ictus, resultando en una tasa extremadamente baja de trombólisis del 1%.
More than half of the patients, 52%, did not know the time of onset of symptoms, and 26% arrived at the hospital more than 12 hours after their symptoms had appeared. This prevented the administration of thrombolysis, which is the treatment to treat a stroke, resulting the thrombolysis rate in Panama was 1%.
Como resultado, a su egreso hospitalario, más del 60% de estos pacientes presentaban un puntaje elevado en la escala de ranking, que mide el grado de discapacidad funcional. Esto representa una carga importante para nuestros sistemas de salud y significa una pérdida considerable de años de vida productiva.
As a result, upon the discharge of these patients from the hospital, more than 60% had a high ranking scale, which is the degree of your functional disability. This represents a significant burden in their healthcare system and means a considerable loss of years of productive life.
Este hallazgo refuerza la necesidad urgente de intensificar las campañas de educación pública, enfocadas en el reconocimiento temprano de los síntomas del ictus y en la importancia de buscar atención médica inmediata. Además de estas intervenciones en prevención, promoción y atención aguda, en Panamá estamos avanzando firmemente en la certificación internacional de nuestros hospitales en el manejo del ictus.
This finding reinforced the urgent need to intensify public education campaigns focused on the early recognition of stroke symptoms and the importance of seeking immediate medical attention. In addition to that, in Panama, they are doing a promotion in acute care, and they are firmly focused on advancing in the certification. They are doing the certification on hospitals, on stroke management, together with the World Stroke Organization.
Actualmente contamos con 2 hospitales privados certificados, la Clínica Hospital San Fernando y el Hospital Pacífica Salud. Este año el Ministerio de Salud trabaja de manera coordinada con el Hospital de Panama Clinic, uno de los centros más importantes de la capital, para convertirlo en el tercer hospital privado certificado con el aval de la Global Stroke Association. Entiendo que próximamente será visitado por una distinguida comitiva de ustedes.
Currently, in Panama, they have 2 certified private hospitals, which is San Fernando Hospital Clinic and the Pacifica Salud Hospital. This year, the Ministry of Health is working in coordination with the Panama Clinic, one of the most important centers in the capital, to make a third certified hospital with the endorsement of the World Stroke Organization. He understands that it will be soon visited by a distinguished delegation of yours.
Paralelamente, nuestras políticas públicas están orientadas a lograr también la certificación de hospitales públicos de tercer nivel de complejidad, en alianza con el sector privado, para establecer una red nacional integral en el tratamiento del ictus y garantizar una atención coordinada, eficaz y oportuna en todo el país.
At the same time, the public policies are aimed also to achieve the certification of third-level complexity public hospitals, in alliance with the private sector, to establish a comprehensive national network for stroke treatment and guarantee coordinated, effective, and timely care throughout the country.
No quisiera dejar pasar esta oportunidad sin extenderles una cordial invitación al 27º Congreso Iberoamericano de Enfermedad Vascular Cerebral y al 6º Encuentro de Ministros de Salud de la Global Stroke Alliance, que se celebrarán el próximo 13, 14 y 15 de noviembre en la ciudad de Panamá.
He would not like to miss the opportunity to extend a cordial invitation to all of you to the 27th Ibero-American Congress on Cerebrovascular Disease, and also the 6th meeting for the Global Stroke Alliance, which is happening in November 13, 14, and 15 in Panama City.
Será un encuentro invaluable para compartir experiencias, investigaciones y los más recientes avances en el manejo del ictus, con el firme compromiso de unir esfuerzos para mitigar su impacto en nuestras sociedades.
It will be an invaluable and the latest advance to share meeting of experiences, research in stroke management, with a firm commitment to joining forces to mitigate the impact of stroke in our societies.
Panamá se posiciona como un país comprometido con la salud de su población y como un referente regional en la lucha contra el accidente cerebrovascular. Estoy convencido de que juntos podemos reducir significativamente la carga del ictus y nuestras comunidades y construir un futuro saludable, justo y resiliente para todos. Muchas gracias.
Panama is positioned as a country committed to the health of its population and as a regional benchmark in the fight against stroke. He is convinced that together we can significantly reduce the burden of stroke in our communities and build a healthier and fairer healthcare system and resilient future for all of us. Thank you very much.
Muchas gracias, and I think that was very impressive, the tobacco use reduction, because of course smoking increases the risk of stroke, and the fact that you've got the lowest risk of tobacco use not only in Panama but in Latin America. Let me move to Dr. Mohamed Fauzi, radiology advisor to the Minister of Health in Egypt. Can you briefly set the scene about the burden in Egypt and some of the key measures that you're taking to respond?
Thank you so much. First, I would like to say, Melinda, impressed. Wish you all the best. I would like to thank the World Stroke Organization and the Coalition for giving Egypt a chance to present its latest advances and the steps that have been taken for stroke. Stroke is a crisis. It truly is a crisis. You had the very strong chance to go in for 40 minutes. I have seen patients who started to see themselves next day with having a debilitated hand. So awareness, awareness, awareness is the key word. I'm not going to repeat and that has been said concerning stroke and its major crisis and its indications. I'm going to say strategic plans now that we should go, and that's what's happening currently in Egypt, which I wish will happen in all of Africa, actually, because Africa is a continent in need. We, knowing some numbers that I have to say, because numbers means strategy. So in Egypt, currently, we have almost 300,000 cases of stroke per year, which, according to statistics, 10% of them should do thrombectomy, which is almost 30,000, which actually they don't do. We don't even reach 1,000. So this was a red flag that we should really take care of. And also, we have stroke services in Egypt, but they are sporadic services in different hospitals, government and private. But they're not actually under one umbrella and not actually under one protocol and policies and procedures. So all this raised actually a red flag that made us as a government start seeing the importance of working on stroke and putting it on the top of the list. As Bo said, it's very important. So first we started to do the infrastructure base. So in the last 3 years, we installed more than 350 CAT scans. So this was basically to start for the diagnosis of the cases, because you have so many hospitals that do not have CTs, nevertheless MRIs. And then during this, parallel to that, we started installing MRIs. We installed in government hospitals more than 28 MRIs currently. And we installed in the last 2.5 years more than 36 cath labs. This was a true heavy financial burden on the government, but we still, as considering ourselves strategizing under one main thing, which is patient healthcare. So we all go around, not just in Egypt and all over the world. We are patient-centered. Being patient-centered, we should search for the best quality of life for the patient. And with the number of the stroke patients that we are having every year, so we have almost 60% to 70% of these patients, they return home debilitated, as His Excellency just mentioned. And this debilitation causes a big problem to the family itself. So working hard on early detection and early management, this is the primary goal in Egypt, which I think we should transform in all other centers in Africa. So after starting the first phase, which is installation of the machinery, now we're going to the second phase, which is that we have more than 90 primary stroke centers, 35 of which are accredited from the WSO, and the rest are on the process. But comprehensive centers, we have a huge defect in that. And these comprehensive centers, we really need that, because stroke care is not just a thrombectomy or the thrombolysis. Stroke care is the diagnosis from the ambulance himself, ambulance care, till the patient finishes his rehabilitation, whatever the time is, months or years after that. So we put a national plan in the government, in the MOH, in order to start a full-scale comprehensive stroke, when we are being supported by our some of our fellow vendors, like Philips as an example, or organizations like the WSO for accreditation. And we're going to start these centers. We're going to start by 4 centers, first in the center, and maybe in 6 months, we're going to make them 8 centers. They are full-scale comprehensive centers, because the idea is that having the service all over the country is that when you put a stroke center in area, you only have this catchment area where the patient benefits from. But there are the geographic areas the patients don't benefit. So it's how you geographically distribute these centers in order to be able to get as much patient catchment and benefit to the patient as you can. And with this parallel, we start working on educations and training and awareness. And I believe, and the government believes, that true awareness for the community, for the people, to start coming, and when they feel the symptoms, even if they're false symptoms, even if they are just CIAs, to seek medication. This is very important. And we already, as Egypt, have a huge success story in this, in early detection of liver cancer in virus C, and we eradicated completely virus C. And we have a very strong screening program for early detection of breast cancer, to the extent that now, after 14 years, the prevalence of breast cancer decreased significantly in Egypt. So we already did this drill, and we are planning to do it on stroke, because now stroke is put on the top of the list in our work. So having these numbers and ending by a small survey or a study done by some people in health economics in the AUC with the Ain Shams University in Cairo, they did a very small survey. They discovered that early detection and early management and early awareness and early treatment, thrombectomy or thrombolysis, saved the country in this small sample by 325 million Egyptian pounds. And this was a small sample. So putting all these numbers together, and numbers are the key word. I believe in all my work that I have to refer to numbers to take my decision. So now stroke has to be put on the top of the list of our concerns as a government. And we started there, and then we'll take it step by step.
Dr. Fawzi, thank you very much for saying all the steps that the Egyptian government has done to bring stroke out of the shadows, to use Bo's analogy there. Perhaps one last question to each speaker, but a very quick one, because I know that many of you have to go off to meetings. Dr. Fawzi, is there one thing that you think can turn the tide? What would that want to be if we think about this UN high-level meeting coming up?
Awareness, awareness, awareness. When a person complains, he has to seek advice. And early detection, the service has to be present even if you don't have I want to say one thing. We cannot buy so many cath labs. We cannot. We need to fulfill our country need. We need more than 400 cath labs. We cannot do that. We are 110 million. But we can modify our strategy to buy one cath lab that serves both purposes. So we collaborate with all our vendors, fellow vendors. So it's awareness and early detection, early management.
Thank you. A Minister of Health from Panama, one thing to turn the tide. And if you have any specific goal from the UN high-level meeting in New York, please tell us.
Yeah, I think that the awareness, as His Excellency said, the same with the getting the primary attention, the distribution in the country, all over the place, of the attention to the people in their homes and in their villages is very important, because this way the awareness and the early detection will be the key. So we are working hard on the primary attention.
Yeah. Yes, indeed. Early detection and getting people treatment as quickly as possible. Health Secretary, the same question to you.
I would say screening. I think the key is get down to the communities. Don't wait for the patients to come to the hospital. And it starts with NCDs. Start screening for NCDs. We have done a survey, and we have screened 75% of our adult population. And the results are very interesting. It shows the risks we are in. 30% of the population have raised blood. Then 6% have raised blood sugar. So you can see how it is going to come for the next 10, 20 years. So I would say screening is the key. And it is not just hospital-based. It should not be institution-based, but it should be community-based. so that everybody is screened after a certain period of time, and we get the results early, so people can take their important measures. Thank you.
Health Secretary of Bhutan, the Minister of Health from Panama, and the radiology advisor to the Minister of Health in Egypt. Thank you very, very much for sharing your thoughts.
One more word just to invite you all to Panama. You're going to see the Panama Canal, and you will enjoy it there.
Thank you. Yes. Thank you very, very much for taking the time. As we know, there's a very packed agenda at the World Health Assembly. So, we mentioned earlier that the Global Stroke Action Coalition, it was set up in April, and it was to unite stakeholders to drive policy action. The Dutch multinational health technology company Philips is a founding member of that coalition, and I'm delighted to introduce Dr. Angelique Balguit, Portfolio Leader for Neurovascular at Philips, who will talk to us about the stroke care revolution. The floor is yours.
Thank you very much, Claire. Thank you so much. Okay, good afternoon, everyone. I think this was extremely impactful to actually hear, and actually, Melinda, I really want to thank you for sharing your story, because thank you. The thing is, we all know stroke exists. The thing is, it's less known. Heart failure, everybody knows. Chest pain, radiation of pain in your arm. It's recognizable. Stroke in some countries is seen as the spirits they're bad spirits. It's not so clear. You're tuning down. Your brain doesn't work anymore. Brain failure. That's major, and it has such an impact without you feeling alarmed per se. You're a neurologist. You knew what was going on, right? That's often not the case. So we spoke about prevention. We can cut stroke in half by prevention. We spoke about acute care. We spoke about rehabilitation and the role of it, and all of it is important. But during this talk, I would like to spend also a moment on the treatment that has revolutionized stroke care, that we also really want to just put a bit more emphasis about, of what has changed. So, let me put it up here. Oh, I'm not sure if I'm clicking the right number.
Can we just check the slides, that there's the next one that can move?
The green one, right? Yeah. Okay, could you help me just... Oh yeah, there it is, there it is. So we heard about it, the global burden. It's a leading cause of disability. It's a leading cause of stroke worldwide. It costs a tremendous amount of money besides all the human disaster that happens when you have a stroke. And up until 10 years ago, if you had a major stroke, there was really little that could be done, provided you're going to be getting to a hospital where you could get treatment. But 10 years ago, there was a revolution really in stroke. And I speak about a revolution, and I'll speak also more about why it was a revolution in the context of modern medicine. There were 5 publications at the same time published in a New England Journal of Medicine that proved that removing the clot with a catheter out of the brain could reverse the impact of a stroke, could really take out that impact if provided well under the right care. And that was really major. I'm showing a picture here of something pretty revolutionary as well. 100 years ago, Alexander Fleming, he invented penicillin. That was at the time, for pneumonia, the #1 cause of death. And penicillin was able to cure that. And why I'm showing this picture is that actually there's really quite a similarity to the impact of the treatment of stroke that is possible through mechanical thrombectomy, what we just talked about. And to explain that, I'm going to show a graph to talk about the number needed to treat. Number needed to treat basically is a number that indicates how many patients do you need to treat before you get a good outcome or prevent a bad outcome on one patient. And just too illustrative. Of course, lung cancer screening, you screen a lot of people to find one lung cancer patient, and that's logical. Number needed to treat, 219. We spoke about acute coronary syndrome. The number needed to treat to intervene, to perform an intervention on acute coronary syndrome to avoid death, myocardial infarction, or stroke is 39. Alexander Fleming with his invention on antibiotics for pneumonia. Number needed to treat, 6, a really high number. The 2015 papers on mechanical thrombectomy that showed that mechanical thrombectomy was effective to reduce disability is 2.6. This is unheard of in modern medicine. It's a major breakthrough to get this treatment done. So today, stroke care, and I'm speaking stroke care as a whole, so also thrombolysis treatment, which can be life-saving and disability-saving as well. Less than 5% of patients actually get, oh, sorry, I should go back. Less than 5% of all patients get stroke care in the world. If this would be the case for other non-communicable diseases, it would cause an international outcry. It would just not be acceptable. And for stroke, it's a postal code lottery. Where do you live? That determines how good your outcome chances are. Melinda had fantastic healthcare. Stacy had fantastic healthcare. Lots of people do not have fantastic healthcare. And that is something that we really want to fight for and to improve because we can. So is it the cost that is preventing this? We have extensive studies in high-income countries, but also middle-income countries like in Brazil. Sheila has been instrumental in doing the studies and actually showing that it is highly cost-effective and in some cases even saves money to a country if you would invest in providing this comprehensive stroke care. Now, it is not seen as a magic bullet. It is really to be seen as an end-to-end solution. And that's why I'm really proud that we are indeed founding members of the Global Stroke Action Coalition, together with other societies that you see on this slide, but also industry partners. I really like that also Vanessa pointed out, we can really make much more impact by joining forces. And I think it's really important to acknowledge that we have been creating a lot of momentum, and I think it's really been important to do so. And for the our goal for the next high-level meeting at the United Nations General Assembly is to get stroke on the agenda. There are a couple of recommendations that are in the policy brief that has just been published by the Global Stroke Action Coalition to take action, to make stroke care a priority, and to really get it out of the shadows. And with that, I'll thank you for your attention. I really hope that you'll, at Ministries of Health that are going to potentially be at the UNGA, raise your voice and also make sure that it is no longer undertreated. Because if we do not address stroke, our goal on the Sustainable Development Goals around NCDs is not going to it's not going to be achievable. Thank you.
Thank you, Angelique, for very clearly outlining what you hope governments will commit to at that UN high-level meeting. I'm now going to hand over to Professor Sheila Martins, the founder and current president of the Brazilian Stroke Network, the immediate past president of the World Stroke Organization, and an internationally recognized leader in stroke care transformation. And Sheila is going to say a few words about the Stroke Action Campaign and launch a final video that we would like you to watch as you leave this event.
Now I'd like to invite you for a call to action to join us in our effort in put stroke in the global agenda. We are launching today our campaign, Every Minute Counts, to decrease disability, to save a life, to save memories. So we need to start stroke action now. And I'll invite you to sign our letter of support. You can see in your postcard in your seat, you have a QR code to see the letter of support and sign, join us in this effort. And also, I'd like to invite you as policymakers, decision makers, to join us as champions in your countries to start to build stroke care in the entire pathway for stroke in prevention, acute care, and rehabilitation. So to finish, we want to show you a video with our campaign, Every Minute Counts.
Stroke is preventable, treatable, and recoverable.
Recent breakthroughs have revolutionized the prevention and treatment and bring the potential to cut the burden of stroke in half.
Effective stroke treatment and rehabilitation improves patient outcomes and reduces disability and dependency,
elevating the burden on families, caregivers, and communities.
Every minute a stroke is untreated,
1.9 million brain cells die.
every minute counts.
We need
Stroke action
now.
Thank you, Sheila, and I would just like to ask everybody to take the postcard which is on their chair and join in the call on policymakers to make stroke prevention, treatment and care a priority. Thank you very, very much for joining us today. Thank you.